Welcome everyone to the next lecture in the series. Today we'll be covering reactive airway diseases in the transport environment. And I want to frame this practically from the start. Reactive airway disease is one of the most common respiratory emergencies that you will transport, and it spans a huge spectrum from the teenager with their first bad asthma attack to the 65-year-old COPD patient in an acute exacerbation to the toddler with severe bronchiolitis. The core physiology is the same: increased airways resistance, dynamic hyperinflation, and impaired gas exchange, but the nuances of assessment and management differ enough between adults and children and between asthma and COPD that we need to cover both. So let's get into it. First, let's take a walk through the objectives. I want you to be able to distinguish asthma from COPD at a clinical level, not because the transport management is radically different, but because it shapes many oxygen targets and the long-term treatment strategies. Second, I want you to understand the pathophysiology of airway hyperactivity and hyperreactivity, smooth muscle constriction, mucosal edema, mucus plugging, dynamic hyperinflation, because understanding the mechanism tells you why each treatment works. Third, I want you to apply a GINA style severity framework to classify acute asthma and make treatment decisions in the field. And then finally, I want you to have a clear escalation pathway all the way from a mild exacerbation to status asthmaticus and intubation, because in transport, you might need to move quickly from one end of that spectrum to the other. Let's start by defining what we actually mean when we say reactive airway disease. It's a broad clinical term that describes airway smooth muscle hyperresponsiveness. The airways overreact to triggers, constricting and narrowing in a way that causes reversible airflow obstruction. The key word is reversible. Unlike the fixed obstruction of like emphysema or fibrosis, reactive airway obstruction can be partially or completely reversed with bronchodilators, with steroids, and ultimately with time. The three main pathologic components are airway smooth muscle constriction, mucosal edema, and inflammation, and mucus plugging. So that's kind of four, but the mucosal edema and inflammation kind of go hand in hand. But together, these reduce the luminal diameter of the airways, they increase resistance, and they trap air distally. That trapped air, which is called dynamic hyperinflation or autopeep, is one of the most dangerous physiologic consequences, especially in the intubated patient. And that's covered in other lectures as well. Under under your care, every reactive airway patient has the potential to go from moderate distress to respiratory arrest if you don't recognize and treat those mechanisms early. So, to distinguish between the two most common reactive airway diseases, asthma and COPD, when you compare them, it's important not just academically, but because it changes two key management decisions: your oxygen target and your approach to non invasive ventilation. Asthma typically presents earlier in life. The airflow limitation is largely reversible, and the triggers are often identifiable. So, and they are very wide ranging. So, allergens, cold air, exercise, viral infections, um, dust mites, dander, anything that cold air. Oh, I already said that. Very common to trigger an asthma exacerbation. Between attacks, spirometry can be completely normal. COPD patients, on the other hand, are usually presented in older patients with significant smoking history or a biomass exposure history like asbestos, and they show progressive and only partially reversible airway and airflow limitation. And they often have a chronic productive cough as a baseline. In COPD, you titrate supplemental oxygen carefully, targeting a SpO2 of 88 to 92% typically, because many of these patients have a chronic hypercapnic state, so a high PaCO2 at baseline, and they depend on their hypoxic drive. Too much oxygen, too high of oxygen concentration can knock out that hypoxic drive. In asthma, we're less concerned about the oxygen driven suppression and more focused on achieving adequate saturation while aggressively treating bronchospasm. Both conditions benefit from SABA and SAMA combinations acutely, so albuterol, ipratropium, duoneb, with combination of the two, Combivent, the inhaler combination of the two, and both benefit from systemic steroid. But the underlying physiology and the long term trajectory are distinctly different. Assessing the severity quickly and accurately is the foundation of reactive airway management and transport. Your key bedside markers are: can the patient speak in full sentences, in phrases, only in single words, not at all? What's their respiratory rate? Are they tachypnic? Are they bradypnic? Which would indicate a much worse and more severe um, exacerbation. Are they using accessory muscles? What's their SpO2? What's their mental status? A patient speaking in full sentences with only mild tachypnea and a SpO2 above 94% in room air is having a moderate exacerbation. They're uncomfortable, but it's manageable with standard therapy. Um, if you get a patient who can only get out single words, if they're sitting hunched forward, using every accessory muscle, if they've got an SpO2 below 90 on supplemental oxygen, if they're starting to show some altered mental status, that's in severe or near fatal territory, and then everything in between. In pediatrics, pay special attention, extra attention to retractions and identifying where the retractions are, whether they're intercostal, subcostal, suprasternal, um, and also paradoxical breathing, kind of seesaw breathing, because children have much more compliant chest walls and will show these signs earlier than adults. Silent chest, where you can barely hear any breath sounds, diminished or absent breath sounds, despite a visible respiratory effort, that is usually an ominous finding that tells you that airflow is critically restricted. That patient needs aggressive treatment and likely should be prepped for intubation. Transport pearl, the severity can escalate quickly as soon as you leave, as soon as you turn around. So frequently reassessing, planning ahead, even several steps ahead for just in case, what ifs, is super helpful to to make your life a little easier and to benefit the patient as well. So this table is kind of your stepwise acute management algorithm for bronchospasm across the severity spectrum. I want to walk you through it as a sequence because the order matters. Always start with the least invasive and the fastest acting intervention first. So supplemental oxygen to target your SpO2, short acting beta 2 agonists like albuterol, and moderate, or even higher doses, and then escalate deliberately based on the patient's response. For moderate to severe exacerbations, add ipratropium, Atrovent, so Duoneb to the albuterol in the first hour. Um, After the first 3 doses, though, the benefit of continued Atrovent use is much less clear. So it's okay to to double them up with the with Duoneb for the first three treatments. Q20 times 3 for the first hour. But then after that, kind of back off and just go with albuterol in higher doses if necessary. Systemic steroids, which we'll get to in a second, as necessary, because Atrovent you actually can reach toxic levels, and it's only an every 6 hour medication, so we don't want to load them up with Duodeb, especially in kids. Systemic steroids should go in early. The anti-inflammatory effect takes hours to manifest, so the sooner you give them, the better the patient is by the time they reach their destination. In severe exacerbations, where patients are not responding, IV magnesium would be the next escalation, typically given in 2 grams over 20 minutes in adults, and then 25 to 75 milligrams per kilogram in pediatrics, but capped at 2 grams. If you're still not winning, still not turning the patient around, um, start thinking about ketamine, start thinking about Heliox, and start preparing for a potential intubation. We typically do not like to intubate asthma patients because they typically do not do well on the vent, and it's often extremely difficult to get them off of the vent. Intubation for people who are in acute asthma exacerbations is kind of a last ditch effort, and should be avoided unless absolutely necessary. Switching gears to COPD. COPD exacerbations with significant bronchospasm are going to be one of the most common high acuity transports that you do in terms of a patient with a respiratory compromise. And there are a few key principles that separate good COPD management from mistakes that you may likely see all the time. First is oxygen, controlled oxygen. Um, I've seen providers give COPD patients like 15 liters or more by a non-rebreather just as a reflex. Oh, they're desatting. Oh, their sat's only 78. What do? Put them on a non-rebreather. Eh. But in the chronic CO2 retainer, that can blunt or stunt or knock out the hypoxic drive that they're relying on and actually worsen their hypercapnia quickly. The target SpO2 for COPD at 88 to 92%, that exists for a reason, um, and you should always avoid sudden jumps, especially up to 100% FiO2, unless they're in some peri arrest and you're gonna intubate and it's a life-threatening situation. Um, Instead, titrate up from a low-flow nasal cannula. Um, go to a Venturi mask. Go to a Veni mask. Those um, you can regulate the actual FiO2 delivered, and that tends to work better than even a standard nasal cannula in a lot of cases, especially in moderate COPD exacerbations with bronchospasm. Um, Try to avoid the simple mask, avoid the partial rebreather, avoid the non-rebreather. If they are not saturating well on a standard nasal cannula, or if their work of breathing is too much, or you can't oxygenate, then go up to a venti mask. And you're free to start high. Start with the orange adapter, 50%, and I believe it's 15 liters, maybe I think it's 12 liters. Um, just a little caveat here, a little segue. For Venturi masks, I know there's no picture on the slide here, but a venti mask, right? Um, the flow on the adapter is the flow that needs to be set on the flow meter. So if it's a 50% venti mask clip or adapter, and it says 12 liters, I'm just trying to go off of memory, um, set the flow meter at 12 liters. If you turn the flow up higher than what it says on the adapter, that can actually make things worse. And it will not increase the actual FiO2. The FiO2 is dependent upon the air entrainment port on the Venturi mask, as well as the um, amount and rate of flow delivery. So, I mean, we see it all the time in the hospital. The nurse was freaking out because their COPD patient was desatting, and they were on a 50% venti mask, and they just cranked the flow up. Well, that that is not going to do the patient any good. You need to reassess and figure out what else to do. Uh, if you have an end tidal CO2 monitor hooked up, watch that. Watch it for a trend. Um, that can be a good, really good, key piece to noticing how your patient is doing over time. So, all right. Second, so we've covered oxygen. Second are bronchodilators. Um, Albuterol and ipratropium, together duoneb, they provide more bronchodilation than either one of them alone in COPD. So we call that potentiation. So what the drug interactions potentiation. If you give let's say you've got bronchodilator A, when given by itself, improves lung function 20%, and then you've got bronchodilator B, let's call it Atrovent. You give that by itself, and the improvement is 20%. Well, Duoneb, if that were the example, the efficacy or the improvement would be greater than the sum of each of them individually. So, say instead of 40%, it's 60% improvement. Either way, administering them together as one as Duoneb or Combivent in an inhaler form, that is superior to giving just one or the other. Um, the reason for that is ipratropium, so Atrovent, is particularly effective because the parasympathetic tone is a bigger driver of bronchospasm in COPD than in asthma, which is why we typically don't give asthmatics Duoneb, we just give them albuterol. Um, Third, we've got steroids. So, steroids in the form of IV or oral, not so much inhaled. So the inhaled corticosteroids, those are all long-acting medications. They take hours to take effect, and they're not going to do your patient any good in the time that you are transporting them to wherever you're going. Instead, if you have IV access, IV methylprednisone or oral prednisone initiated early reduces the duration and the severity of the exacerbation as much, if not more, than the bronchodilators. So it's extremely important to get those on board ASAP. That's something that I test my pharmacology students on. It's on their midterm, it's on their final, it's on the next semester's first test, and it's amazing to me how many students just get it wrong time and time again. Crying out loud. Oral IV steroids, systemic steroids in COPD and asthma, those should be on board ASAP. Fourth, we've got NIV, so non-invasive ventilation. So BiPAP or bilevel positive airway pressure. That's one of the most effective interventions for COPD exacerbation when there's hypercapnic respiratory failure. Not so much with asthma. It's uncommon to put an asthmatic onto a BiPAP. COPD, on the other hand, it's a literal lifesaver. It reduces their work of breathing, it improves their CO2 clearance, and in many patients, it averts or it staves off intubation entirely. We use it early, use it aggressively, and don't be afraid of it at all. The scariest one for reactive airway diseases, in my opinion anyway, is status asthmaticus. Um, that is when you've got refractory bronchospasm that does not respond to standard treatment. It's one of the most dangerous situations in transport medicine, one of the most dangerous situations in respiratory ailments in general. Um, and intubation in this population carries serious and significant risks that you need to understand before you reach for that laryngoscope or that glide scope if you're lucky. The red flags that tell you that you're headed towards respiratory failure, those are exhaustion, rising EtCO2 despite respiratory effort, altered mental status, and silent chest or diminished slash absent breath sounds. When you see any of those, you'll want to maximize their medical therapy immediately and then prepare for potential intubation. If you do have to intubate, um, for one, use the largest ET tube that you can safely place. You want the lumen size to be as large as possible. And typically that's not something that we look at. I mean, standard adult gets an 8.0, or adult male gets an 8.0, maybe a 7.5 if they're on the smaller side, or greater than 8 if they're on the larger side. Typical adult female get a 7 or a 7.5 ET tube, but um, when in doubt, like go big or go home. To minimize the resistance for one, and to allow for adequate suctioning for two. Once you intubate, if you intubate a status asthmaticus patient, the ventilator strategy is a little different. You are okay with permissive hypercapnia. You're okay with their CO2 being a little high and their pH, being a little low. You want a low respiratory rate, so 8 to 10, 8 to 12 breaths per minute in adults, lower end of normal in peds. You'll want a modest tidal volume, so take that 6 to 8 mLs per kilogram predicted body weight calculation and err on the side of shoot for the middle even. Start with 7 and go from there. And always allow a long expiratory time with an IE ratio of at least 1 to 3 or 1 to 4. Why? Because the fundamental problem in the intubated asthmatic is air trapping. Lots of talk today on air trapping. If you don't give the lungs enough time to exhale, auto PEEP builds and can cause tension physiology. It can cause hemodynamic collapse. It can cause a pneumothorax. And after any deterioration of the patient post-extubate or post-intubation, I'm sorry, after any deterioration post-intubation, think the dopes mnemonic. Okay, so if you've got issues after you intubate a status asthmaticus patient, think dopes. So D for displacement. How's the endotracheal tube? Is it where it's supposed to be? Obstruction. Make sure that you can pass a suction catheter. Um, Pneumothorax. Keep an eye on their FiO2 and their correlating SpO2. Take a look at their chest symmetry. You know, do they have asymmetrical breath sounds? Listen to their breath or asymmetrical chest movement. I'm sorry. Do they have asymmetrical breath sounds? Are they diminished on one side more so than the other? Things like that. So that's P. E for dopes is equipment failure, which can absolutely happen, and then S is stacked breaths, and that's that auto triggering, that breath stacking that I talked about in a previous lecture, and that is due to incomplete exhalation. The patient wants to take a breath before the exhalation process is complete. So special reactive scenarios in transport. This slide covers 3 reactive airway scenarios that you'll likely see in transport and that require thinking beyond the standard asthma algorithm. First is an anaphylaxis related bronchospasm. Whenever you have a suspected anaphylactic reaction, um, number one, it's gonna cause bronchospasm. The primary treatment for that is epinephrine or racemic epinephrine, um, not albuterol. So if it's an anaphylactic thing, hit them with an EpiPen. If they have upper airway swelling as a result of the anaphylactic reaction, give them a racemic epinephrine nebulizer treatment. Give them 2, give them 3. Do not give albuterol. Albuterol will not do anything for that. Albuterol is not all betterol. Okay, it does have its purpose, but it's way overused and used for all kinds of things that it shouldn't be. Epinephrine, though, that addresses that mast cell degranulation. Remember in well, earlier lectures talking about um, airway hyperreactivity and inflammation and mucosal edema and swelling, um, all of those things that deal with mast cell destabilization with regards to some sort of allergic or anaphylactic trigger. Um, Epi is the drug that addresses that. It addresses both the vasodilation and indirectly the bronchospasm simultaneously. Albuterol is an adjunct. It's not going to hurt anything, but it should not be the lead drug that you give. Second, smoke inhalation or any other inhalation type of injury. Um, Smoke inhalation or any kind of inhalation burn, those produce a chemical tracheobronchitis that can cause severe bronchospasm, severe, plus progressive upper airway edema or swelling. So in that case, you would want to treat the bronchospasm with bronchodilators, but also watch their airway, their upper airway carefully and not being afraid to intubate early if you see signs of upper airway constriction, because edema in cases of inhalation injury can progress very rapidly and make intubation later a heck of a lot harder. Early intubation in inhalation injuries is a good thing to consider. Third, we've got a pediatric viral-induced wheeze and bronchiolitis in children under 2 with bronchiolitis. The wheeze, try telling your nurse this. Hope there are no nurses in the class. The wheeze is driven primarily by airway edema, swelling, and mucus plugging. from the viral injury, not from smooth muscle constriction and bronchospasm. Short-acting beta-2 agonists like albuterol, there's limited evidence of any kind of efficacy in bronchiolitis, and the mainstay of treatment is just supportive measures. So humidified high flow oxygen for increased work of breathing, positioning to make sure that they can, breathe, as comfortably as they can, suctioning whenever you've got visible secretions or audible if you can if you hear them on auscultation. Severe cases, high flow therapy, non-invasive ventilation. I mean, plenty of bronchiolitis kids get intubated and are going to pick you for for days. Um, but understanding that the root cause is swelling from the viral illness. That swelling causes the wheeze. Um, don't give them albuterol. Give them epi, give them a racemic epi, give them steroids, nebulize, budesonide, which is Pulmicort. Throw some Heliox at them in severe cases if they're, if they can't get air in because their upper airway is so swollen. Um, go those routes. Don't go the bronchodilator route. So one of the ways to look at it is upper versus lower airway, bronchospasm versus swelling versus mucus, and then target your interventions accordingly rather than just give them another treatment, give them another breathing treatment. If it's an upper airway issue, albuterol will do nothing. Albuterol does not affect anything in the upper airway. It only affects the beta 2 receptors on the airway smooth muscle in the lower airways, in the distal airways. Your racemic epinephrine, that will only work on upper airway swelling. It does absolutely nothing or very little for like actual bronchospasm. Without beating a dead horse, let me close with the core principles that I want you to carry out from this lecture today. Reactive airway disease is a physiological problem that includes increased airways resistance, dynamic hyperinflation, a VQ or ventilation perfusion mismatch, and every treatment that you choose is targeting one or more of those mechanisms. The severity assessment should drive your escalation in care. Um, use their speech, use their work of breathing, use their SpO2, use their mental status. Use those four things as your four pillars when you're assessing. In COPD, controlled oxygen is important. And early NIV, early non-invasive ventilation, early CPAP, early BiPAP. Those are probably the most important differentiators from asthma management. Um, Intubation status in asthmatics um, is a high risk intervention, especially in status asthmaticus patients, even though that might be the only way that you can get an airway. Um, if you exhaust every medical option first, and if you do intubate, then ventilate via the obstructive disease pathway physiology. So low rate, long expiratory time, permissive hypercapnia, and a constant monitoring for any kind of auto peep and pneumothorax. And then finally, for anaphylaxis, inhalation injury, and pediatric bronchiolitis, um, those all need modified approaches that you rehearse them mentally um, so that you're prepared. I mean, think about the differential diagnosis. Think about if you're going to Decatur to pick up a 2-month old who's um, who's on oxygen in their primary care facility. They need to go to they want to go, admit them to a pediatric unit. They're on 2 liters at 93%, and they're snotty and have a wet cough and a fever, and they're just inconsolable, miserable. What's your care plan? You give them albuterol because you hear some wheezes? No. Do you suction them? Yeah, if they need it. Do you monitor their SpO2? Yep. Can you deliver higher flows for oxygen, either with a true high flow device or even one of those Salter cannulas that aren't true high flow devices, but in a peds setting could serve as one? Yeah. Flow, especially flow that exceeds the patient's own inspiratory demand, that is proven to reduce work of breathing and improve patient comfort, and it helps to facilitate the healing process, and kind of mitigate the deterioration of the patient from that condition. All right. Thanks for sitting through another one.